A dog may walk up to food enthusiastically, sniff it, and then suddenly turn away. Cats may approach the bowl and just stare at it. Those moments are clinically important because they represent true nausea.
Welcome back, VetFolio Voice family. This episode is sponsored by Decra, and for this episode, I was joined by Dr. Chris Byers. I was so excited to have him back on the podcast. You may hear me say this a little bit. I feel like I've been on a run where I've been fortunate enough to welcome back some of the brilliant minds that I've worked with before, and Dr. Byers definitely falls into that category. I love every opportunity I get to just nerd out over critical care and internal medicine, and this episode was certainly no exception. And really, I kind of have to thank Dr. Byers because even though I'm supposed to be the host and keep us on track and make sure we cover all the information that we're trying to without going on too many side quests along the way, it was actually him who helped rein me in on this episode when I wanted to really dig into like the nitty gritty pathophysiology of nausea and vomiting and shock, all these different processes. So good news, he helped keep us on track. We made sure we kept it clinically relevant. And he really did a wonderful job, as always, differentiating between managing nausea versus just stopping vomiting. He walked through the clinical picture we tend to see in animals that are experiencing nausea, even if they're not vomiting. He talked about the extensive differential list for nausea and vomiting that goes far beyond the GI tract, and management strategies in these patients that certainly hinge on stopping the nausea and the vomiting, but don't overlook the importance of managing the underlying cause of the nausea and vomiting. And be sure to stay tuned all the way to the end to hear Dr. Byers' answer when I ask him what the wildest foreign body he's ever managed was. So just for reference, my answer to that question was carrots. You heard that right. I did see a patient who obstructed after eating carrots. And let's just say my answer had nothing on his. So make sure and stay tuned all the way to the end. Let me introduce Dr. Byers and we will get into our episode. Dr. Chris Byers is a practicing board-certified veterinary emergency and critical care and small animal internal medicine specialist, as well as a certified veterinary journalist based in Omaha, Nebraska. He received his Bachelor of Science degree as a University Honors Scholar in Animal Sciences from Colorado State University and his Doctor of Veterinary Medicine from Cornell University. Dr. Byers is the co-author of the textbook Feline Emergency and Critical Care Medicine and the upcoming textbooks Canine Emergency and Critical Care Medicine, Collaborative Approach to Small Animal Emergency and Critical Care, and Collaborative Approach to Small Animal Internal Medicine. He's also published chapters and articles in numerous textbooks and peer-reviewed medical journals. Dr. Byers is a renowned international speaker, and his clinical areas of interest are hematology, fluid therapy, sepsis, and endocrinology. All right, let's talk about nausea and vomiting.
Are you passionate about animals and love helping people? In the fast-paced world of veterinary medicine, exceptional client communication is just as important as quality pet care. As a customer service representative, you're the heartbeat of the practice, the first and last person clients see. You provide comfort, support, and trust in every interaction. This course is designed just for you. It's interactive and practical, featuring real-world in-clinic video scenarios, engaging knowledge checks, and printable resources to give you the tools, confidence, and strategies to handle any challenge and elevate the client experience. Register today for the Certified Veterinary Client Service Representative course on VetFolio.com.
Dr. Byers, thank you for joining me again. I always enjoy our conversations because somehow you manage to fit so much information into a short conversation, and I walk away like, wow, I learned so much just in an hour or whatever we have.
No, thanks. I appreciate it. I've been looking forward to this one because You know me. I like to geek out, and wow, we get to do that today.
Yes, I know. I think we had to kind of rein ourselves in a little bit when we were deciding what we were going to talk about, or this was going to be a 3-hour conversation.
Exactly. But I promise we're going to keep it clinically applicable. I promise we're not going to do the deep dive into the physiology textbook.
Yes. As much as, and I will make the same promise, the same commitment of try to keep my questions more, like you said, clinically relevant. And we're talking about something that's really important, nausea versus vomiting. I remember one of my ECC clinicians in vet school was very big on making sure that we were recognizing the signs of nausea in our patients because they can be really subtle. So let's start there. Can you kind of give me your take of what you look for to indicate that a patient might be nauseous?
Absolutely. I 100% agree with that colleague in that one of the most important concepts in veterinary medicine is recognizing that nausea and vomiting are not synonymous. Vomiting is that observable event, while nausea is a subjective sensation. And because our patients can't verbalize that sensation, we have to identify it through behavior, posture, facial expressions, and even physiologic responses. And I think you'd agree that many of our patients are nauseated long before they ever vomit. And if we as clinicians wait until active emesis occurs before intervening, we're already behind. So some of the earliest and most subtle signs of nausea are behavioral. A dog may walk up to food enthusiastically, sniff it, and then suddenly turn away. Cats may approach the bowl and just stare at it. Those moments are clinically important because they represent true nausea rather than simple inappetence. Lip licking, another classic sign, repetitive swallowing, exaggerated tongue movements, tyolism or hypersalivation are also very common. Many patients just become restless, or they pace, they pant, or repeatedly reposition themselves. Others become withdrawn or quiet. Cats, in particular, can be extremely subtle. So they may loaf tightly or hide in the back of the cage, keep their eyes partially closed, become less interactive. Some develop those exaggerated swallowing motions or even intermittent gagging behavior without the true vomiting. And so our veterinary technicians, our credentialed veterinary technicians, are often exceptionally good at identifying these changes because they're the ones that spend prolonged periods observing these hospitalized patients. Dogs, they frequently demonstrate their nausea through grass eating, frantic drinking, anxious pacing, or even repeatedly asking to go outside. Some owners, I think I've heard them describe their dog as, looking quote unquote uncomfortable or unable to settle. Those vague descriptions, I think, can actually be very meaningful. Posture, I think, also matters. I think nauseated patients often appear hunched. They're tense through their abdomen, or they're often reluctant to lie down comfortably. And in severe cases, they develop that open mouth drooling, the trembling, and sometimes obvious distress. One thing that I really emphasize to colleagues, to interns and residents, nausea can persist even after vomiting has stopped. Clinicians sometimes assume that if emesis is controlled, the patient must feel better. But many patients continue experiencing significant nausea despite the cessation of vomiting. And that distinction becomes clinically important when selecting medications. A patient may stop vomiting after meropitant administration, but still refuse food, lip lick, drool, or appear uncomfortable because the nausea itself persists. And that's where medications like ondansetron may provide additional benefit. And we should also remember that nausea is not always gastrointestinal in origin. Vestibular disease, pancreatitis, renal failure, hepatobiliary disease, DKA, sepsis, toxins, intracranial disease, pain, and yes, even severe anxiety can all activate nausea pathways. And from a physiologic standpoint, nausea has consequences beyond patient comfort. Nauseated patients, they often are reluctant to eat or drink, which worsens dehydration. It delays enteral nutrition. It contributes to muscle catabolism, and it can impair gastrointestinal motility. Persistent nausea also contributes to stress hormone release and obviously overall physiologic deterioration. So I really encourage clinicians and technicians to actively look for nausea rather than waiting for vomiting. If we become better at identifying those earlier and more subtle signs, we can intervene sooner. We can improve patient comfort more effectively and potentially improve overall outcomes.
I love how you just brought that whole thing full circle with so many important points a lot of the points you make about nausea, we can probably relate it back to ourselves. That's a miserable feeling, even if we're not vomiting. And then, like you said, if we have a patient who's vomiting and we stop it, but they're still nauseous, that's where it becomes so important to really make sure we're recognizing those signs of nausea to say, we did stop the vomiting, but we haven't started them eating again. I love how you also wove in some of the differentials there because it really changes how we're going to approach this. Like you mentioned vestibular disease, we might be thinking more of like a motion sickness type of drug rather than a meropitant. And our approach based on our differentials. And then also how nausea and vomiting, they kind of create this vicious cycle of if we have an inappetent pet or a pet who's vomiting and they are worsening dehydration, then we're worsening ileus. Like you said, we're delaying enteral nutrition, which is going to have a negative impact on the overall healing of the gut and everything. And it becomes this vicious cycle. So making sure that we can recognize not just vomiting, but nausea, that we're treating it appropriately based on the differentials, and that way we can, and that we're managing hydration and trying to get enteral nutrition going as quickly as possible. I think you just illustrated all of those points so beautiful. It just like flowed through this whole, the whole way my brain would think through that. So thank you for that.
Well, I appreciate that.
Oh no, it was a great explanation. I was sitting here just like, this is great. This is exactly how I would flow through this thought process. Along those same lines, you mentioned a lot of these differentials, but can you dive briefly a little bit more into how we should consider differentials for nausea and vomiting so we can make sure that we're treating appropriately?
Absolutely. I do think one of the most important things clinicians can do with vomiting patients is avoid becoming overly anchored on the gastrointestinal tract too early. It's incredibly easy to see vomiting and immediately assume GI disease because vomiting is really a manifestation of activation of the emetic center. And there are numerous pathways capable of triggering that response. So when I approach a vomiting patient, I like to divide my differential diagnoses into gastrointestinal and extra gastrointestinal causes. That framework for me helps ensure I don't miss systemic disease masquerading as primary GI disease. Now, for those primary gastrointestinal diseases, we think about inflammatory, infectious, obstructive, ulcerative, infiltrative, toxic, and even motility-related disorders. You and I both know dietary indiscretion remains incredibly common, especially in younger dogs. Foreign material ingestion is certainly a major concern, particularly in patients with persistent vomiting, abdominal pain, reduced fecal output, or progressive lethargy. One of the key distinctions clinically is trying to determine whether we are dealing with functional ileus versus mechanical obstruction, because certainly treatment priorities become very different. The mechanical obstruction often produces repetitive vomiting, worsening dehydration, electrolyte derangements, abdominal discomfort, even progressive gastric and intestinal distension. I think we're all familiar with that. But partial obstructions, those can be deceptively subtle and intermittent. Those are often the patients that vomit for several days, temporarily improve with symptomatic therapy, and then deteriorate again. Chronic inflammatory enteropathy, that's the new term for inflammatory bowel disease. I didn't change the names. I don't care which one people use. I'm going to know what they're talking about. Acute hemorrhagic diarrhea syndrome.
I was going to say, that was where my head went. I'm like, but can we talk about that one? Because HGE rolls off the tongue so much better.
Yeah. Probably tomorrow they'll change 2 more things for us. Infectious enteritis, gastric ulceration, GDV, neoplasia, intussusception, mesenteric torsion, severe constipation or obstipation. Those also all belong on that GI differential list. Don't forget about motility disorders. It's another category that in veterinary medicine we sometimes under-recognize. Some patients aren't obstructed, but instead have delayed gastric emptying or severe paralytic/functional ileus. And sometimes, depending on the part of the country in which you practice, dysautonomia-like syndromes that impair normal transit. One of my favorites, pancreatitis. I think pancreatitis deserves its own discussion because it is one of the most common extra-intestinal drivers of vomiting in dogs and cats. Honestly, pancreatitis is often much more than just GI upset, quote unquote. Those patients develop severe systemic inflammation. They can develop distributive shock, ileus, pain, certainly, endothelial injury, acute kidney injury, and coagulopathies. But vomiting may only be one component of a much larger critical illness picture. Hepatobiliary disease, another major category. Patients with cholangitis, hepatic lipidosis, hepatic neoplasia, gallbladder disease like mucoceles, and even severe hepatocellular dysfunction often become profoundly nauseated. So hyperbilirubinemia, elevated liver enzymes, hypoglycemia, coagulopathy, or hepatic encephalopathy, those things can help redirect the diagnostic workup. Then we can also move into endocrine disease, which is incredibly important because many endocrine disorders present initially as the vomiting patient.
Oh, now, yeah, the ADR.
I love endocrinology. I love it. Hypoadrenocorticism, Addison's disease, is one of those classic examples. These patients can look exactly like primary GI disease: vomiting, diarrhea, lethargy, weakness, abdominal pain, hypoglycemia, even hematochezia. Sometimes, not always, and not nearly as often as we would like to think, at least in my experience, but sometimes the electrolytes provide the clue. But again, not always. Remember that quote-unquote atypical, or what we now prefer to call eunatremic, eukalemic Addison's patients can lack those classic sodium and potassium abnormalities. DKA, diabetic ketoacidosis, another major consideration. These patients present with vomiting, dehydration, the electrolyte derangements, ketonemia, obviously the metabolic acidosis, and typically severe systemic compromise. And now with the increasing use of sodium glucose cotransporter 2 inhibitors in cats, we also need to think about euglycemic diabetic ketoacidosis, where glucose may not be profoundly elevated despite severe ketoacidosis. What else? Renal disease, another huge contributor to nausea and vomiting. Uremic toxins, they directly stimulate nausea pathways and contribute to gastric ulceration, delayed gastric emptying, severe anorexia. These patients, as you and I both know, have concurrent dehydration, electrolyte abnormalities, hypertension, and certainly acid-base derangements. But let's talk about a category that everybody seems to overlook too often. So I always appreciate the opportunity to broach it. Neurological disease. Neurological disease is another category that I feel we as veterinary professionals sometimes overlook. Increased intracranial pressure, intracranial neoplasia, meningitis, encephalitis, vestibular disease, seizure disorders. They can all stimulate vomiting centers. Vestibular patients especially may appear profoundly nauseated, even though the GI tract itself is completely normal. Toxins, they should always be on the list, right? NSAIDs, rodenticide, xylitol, heavy metals, toxic plants, list goes on and all. They can all produce vomiting. So getting that history, a really careful exposure history, is incredibly important. Pain itself can trigger vomiting. Think severe intervertebral disc disease or pyometra, pancreatitis, trauma, urinary obstructions, even septic processes. They may all produce nausea through pain and inflammatory pathways. And I think perhaps the last thing that I'll mention in this list is cardiopulmonary causes, because I think we sometimes forget those. Severe hypoxia, pulmonary thromboembolism, right-sided heart failure, pericardial disease. Those also may contribute indirectly to nausea or GI congestion. One thing I really encourage clinicians to ask themselves early on is, does this patient look sick enough for simple gastroenteritis? That question for me can be extremely valuable. If a patient is profoundly lethargic, hypotensive, hypothermic, severely painful, acidotic, hyperlactotemic, or you're documenting or the patient is demonstrating organ dysfunction, we need to widen the differential list aggressively rather than assuming uncomplicated GI disease. So I think it's really important to avoid viewing vomiting as a standalone problem. Vomiting is a symptom. It's a clinical sign. And our job as veterinary healthcare team members is to determine what physiologic process is driving it. So practically speaking, the best diagnostic approach, it combines careful history, thorough physical exam, point of care assessment, directed laboratory testing, imaging, and then, I can't harp on this enough, serial reassessment. You don't just examine the patient once, you need to be continually reevaluating them, because honestly, some of these patients declare themselves over time. The vomiting patient you initially think has gastroenteritis may become the pancreatitis patient, the obstructed foreign body patient, the Addisonian patient, or the septic abdomen patient 6 hours later. That's why reassessment is such a critical skill, especially in emergency and critical care medicine.
Yeah, absolutely. By the time they show up at the ER, I mean, there's usually some additional signs. I love how you divided that up into body systems. I didn't have cardiopulmonary on my radar as a source of vomiting, but when you say it, it makes sense. Some of these differentials, I'm hearing them, I'm like, oh, that just seems mean, like an IVDD case that's now vomiting. And I'm going, oh, that sounds even worse. Same with cardiopulmonary and things like this. I'm also hearing the way my brain is interpreting it, a lot of crossover amongst these differentials, like AKI and pancreatitis. And there was something else you said where I was like, oh, and then those, like, these types of things can go together. Thinking about functional ileus as a sequelae of maybe like a pancreatitis or something along these lines. So a lot of overlap here where, like you said, when they get to this point where we're beyond a simple gastroenteritis and an otherwise like pretty well patient, we really need to do the digging that you're talking about, the careful history, the diagnostics, things like that. What are some key blood work findings that we could look for? Because certainly imaging, we think about imaging when we're talking about vomiting to make sure we don't have an obstruction or a mass or something along those lines. But if we're talking disease processes outside of the gut, like hepatocellular disease, even like pancreatitis, AKI, or chronic kidney disease, all these different things, sepsis, blood work is going to cue us into a lot of what's going on here. So what are some kind of key things that we should keep on our radar, be looking for?
Blood work is really about identifying both severity and systemic involvement. One thing I encourage clinicians to evaluate early is perfusion status. So something like the shock index can be very useful in dogs. If the heart rate is disproportionately elevated relative to systolic blood pressure, that may suggest occult shock before overt decompensation develops. I also think point of care monitoring tools are underutilized in vomiting patients. Lactate measurement can help us assess tissue perfusion and response to resuscitation. So serial lactate trends, they're often much more valuable than a single absolute number. Glucose monitoring, also very important because hypoglycemia or hyperglycemia may dramatically alter our differential list. Similarly, in selected patients, something like bedside beta hydroxybutyrate monitoring can be incredibly helpful, and it's quite economically friendly to measure bedside BHB. And that's obviously especially true in diabetic patients where we're concerned about DKA or eDKA. And then you have, the quote unquote routine blood work, complete blood count, biochemical profile. Those may reveal dehydration or hemoconcentration, azotemia, a wide variety of electrolyte derangements, inflammatory leukograms, or the lack of a stress leukogram, elevated liver enzymes, hyperbilirubinemia. You may measure pancreatic lipase and document elevations there, and then acid-base disturbances of all kinds. So that blood work helps us decide whether this is a simple outpatient vomiting case or one that requires ICU level stabilization.
And when you talk about acid-base derangements and some of these other measures, I have been very appreciative being in emergency for the last year of having those types of tests readily available. But some of these I really didn't have, thinking from a general practice standpoint. So what would you say to a general practitioner who's like, I don't have all of these tests. I have a CBC chem and that's kind of what I have available to me.
I would say you're normal and you shouldn't stress. But I don't run a lot of venous blood gases, with rare exception. I don't find that running acid base assessment really changes what I'm going to do. And so I love endocrinology, and I've been privileged to chat around the country about EDKA, this new form of diabetic ketoacidosis that is a rare complication when we treat cats with sodium glucose cotransporter 2s inhibitors. The current accepted diagnostic criteria are ketonemia, metabolic acidosis, and a relative euglycemia. So typically we're talking about the glucose being less than 250 milligrams per deciliter or less than 13.9 millimoles per liter. And so when I'm out and about chatting with colleagues and interacting with them about this syndrome, what do I often hear? Well, I can document glucose and I can check ketone status, but I can't confirm whether the patient is living with metabolic acidosis. And what I tell those colleagues is, if you have a patient who is presented to you sick, they're on an SGLT2 inhibitor, and you document ketonemia, you document ketosis and relative euglycemia, you should just assume that they have EDKA and treat them as if they have EDKA, even though you couldn't technically put that final check in the box for metabolic acidosis because you couldn't measure acid-base status in your hospital. You're putting every other dang check in the box. Just make a presumptive diagnosis of EDKA, have an informed conversation with the owners, and start appropriate therapies for EDKA.
Sure. Yeah, because it would, at least in the acute period, it's not going to change a whole lot about your approach. You're going to, implement a lot of the same treatments you would, whether it's diabetic ketosis or diabetic ketoacidosis.
In this day and age where we are seeing costs escalate and we're seeing pet owners experience more significant financial challenges, if we can take a more, I'm just going to say a more respectful approach to their limited finances while still making the patient a priority, I think that serves everybody and aligns with what is commonly referred to these days as spectrum of care. I just call it practicing medicine.
I love it. I love it. That's how we've had to practice medicine for a long time, is how to figure it out. But I think we are learning more about communication and how to make these decisions and all of this. But it's so important. And I'm so glad you bring that up, of even if you don't have all the bells and whistles, let's say, like pH and things like this at that exact moment, it doesn't mean that you don't have the information you need to implement a treatment plan.
Exactly.
I love it. Gosh, we could go down that road for a ways. I have all kinds of thoughts there. But sticking with the vomiting patient, let's talk about imaging, because of course, outside of the blood work findings, imaging is super important. And there's a lot that we can rule out with, say, radiographs and ultrasound. Those are the two primary ones. Of course, if we're talking neurologic, maybe we're getting into CT and MRI, but primarily radiographs and ultrasound when we're talking about the vomiting patient. So how do you approach imaging recommendations in the
Yeah, I think imaging is one of the most important tools we have for determining whether a vomiting patient has medical disease, surgical disease, or systemic involvement. And honestly, imaging should never just become a checkbox exercise where we ask, do we see a foreign body? The goal is to use imaging to better understand the patient's physiology, the severity of disease, the potential underlying cause. And abdominal radiographs remain incredibly valuable and should not be underestimated. They are often the first-line modality because they're widely available, rapid, and can answer several clinically important questions. Radiographs can identify mechanical obstruction, gastric dilation, intestinal plication, free abdominal gas, severe constipation or obstipation, organomegaly, loss of serosal detail, mineral opaque foreign material, abnormal gas patterns, large abdominal masses. The list goes on. And honestly, serial radiographs are often more valuable than a single study. Watching progression of bowel dilation, movement of intestinal gas patterns, or worsening gastric distension over time can help differentiate functional ileus from evolving obstruction. One of the most important things clinicians need to remember is that radiographs should always be interpreted in the context of the patient in front of you. A mildly abnormal bowel pattern in a bright, hydrated outpatient is very different from the same radiographic findings in a lethargic patient with an elevated lactate, abdominal pain, or poor perfusion parameters. Point of care ultrasound. POCUS. I think you and I would both agree it's become tremendously valuable in emergency and critical care medicine. And honestly, even clinicians with relatively basic ultrasound skills can gain clinically meaningful information very quickly. Just from a gastrointestinal standpoint, POCUS can help identify gastric distension, fluid-filled bowel loops, reduced GI motility. You can see intestinal plication. You can find foreign material. Certainly, you see peritoneal effusion, pancreatic enlargement or surrounding inflammation, thickened intestinal loops, free abdominal gas in select cases. So POCUS is especially useful because it allows that real-time assessment directly at the patient's side. You're not waiting for imaging processing or transporting an unstable patient through the hospital. That immediacy can be incredibly valuable in critical patients. One thing I particularly like about POCUS is that it encourages healthcare team members, and I'm including technicians in this, not just veterinarians. It encourages them to think dynamically rather than statically. You're not just asking, what does the abdomen look like? You're asking, what physiologic processes may be occurring right now? For example, reduced intestinal motility may support concern for ileus associated with pancreatitis, sepsis, electrolyte derangements, systemic inflammation. Free abdominal fluid in a vomiting patient immediately broadens your differential list substantially. Severe gastric distension may increase concern for obstructive disease or delayed gastric emptying. But POCUS can also help identify findings outside the GI tract that may be contributing to vomiting or nausea. So we could find changes suggestive of hepatobiliary disease, urinary obstruction, pyometra, pericardial effusion. That one just comes to mind based on a patient that I saw yesterday. Systemic disorders that are masquerading as primary GI disease. Now, formal abdominal ultrasound still plays an incredibly important role overall as well. A comprehensive study performed by an experienced ultrasonographer can provide detailed assessment of intestinal layering, lymph nodes, pancreatic architecture, hepatobiliary structures, etc. And those are things that may not be appreciated or aren't intended to be appreciated on radiographs or focused ultrasound. I think another important concept is that imaging findings are not always black and white. Partial obstructions, pancreatitis, inflammatory conditions, functional ileus, they often produce overlapping imaging appearances. And so that's why serial examinations, repeat imaging, and reassessment, they're so important in vomiting patients. And honestly, sometimes the most important imaging finding is recognizing how sick the patient does or does not appear relative to the imaging abnormalities. A patient with profound systemic compromise and relatively mild imaging findings, that patient should still raise concern that significant underlying disease may be evolving. So ultimately, imaging should help answer several critical questions, right? Is there evidence of surgical disease? Is there evidence of severe inflammatory disease? Could this be functional ileus rather than obstruction? is there evidence of extra gastrointestinal disease? Does the severity of imaging findings match the patient's clinical presentation? Because a vomiting patient is rarely just a vomiting patient. Imaging helps us determine what larger physiologic process may actually be driving the clinical signs.
Man, so much good stuff there. Couldn't agree more. I love that you brought up abdominal radiographs and the importance of it, because I do think sometimes they get pushed to the side in lieu of ultrasound. But in reality, like sometimes they're more helpful when we're talking particularly about obstructive disease or something along these lines. And so oftentimes I'll explain it to owners and say, these are modalities that complement each other. One is going to give me one piece of information. The other is going to give me another piece of information. It's not always one or the other that's better or worse. And I love that you bring up serial exams. I know this, and yet I had to have a conversation with a criticalist I work with just this week who said, the patient just hasn't given you enough information. You just don't know yet. And you can tell them, this is what I know so far, but we're going to have to keep an eye and see how things progress before we really know where this whole process is going. And so not being afraid to say, and really when I'm concerned about obstructive disease, this is often how I talk to owners, which is why I was like banging my head against the wall going, Cassie, you know this, but you're still like struggling to say I don't have the answer yet. But particularly when I'm talking about GI obstruction with pet owners, I'll tell them, I'll say, sometimes I can take this x-ray, and if there's an obstruction, I can tell you right now. Most of the time, it's kind of vague, and we're talking about abdominal surgery here. So usually I can get a good baseline, but I'm going to have to come back and check again. So if I come back and tell you that, that's just how these things go sometimes. So yeah, not being uncomfortable with saying, I need this serial exam. I need to see how this progresses in the context of what my patient is doing. I feel like every single one of these questions we could do a whole podcast episode just on these, because I'm going, man, I can go down that road too. And I have so many more thoughts and questions. I do want to be, conscious of time and things like that. So I guess maybe to wrap it up, we mentioned this at the very beginning, talking about changing our treatment modalities based on our differential list and the patient in front of us. So can you expand on that a little bit of what types of treatments we would be reaching for based on the patient in front of us and what we're seeing?
Yeah, one of the most important concepts in managing these patients, again, is recognizing that nausea and vomiting are not the same thing. And we often use those terms interchangeably in clinical medicine, but physiologically, they are different processes. Vomiting is the physical act of expelling gastric contents. Nausea is the subjective sensation that precedes it. And honestly, I think nausea is frequently under-recognized in veterinary medicine because our patients cannot verbally tell us they feel miserable. We talked about it. A patient may stop vomiting, yet still feel profoundly nauseated. Those are the dogs that are walking up to the food, sniffing it, lip lick, turn away, drool. They just look miserable. Cats, very subtle, right? Loaf tightly, hide, become withdrawn. They salivate. But that distinction matters. And why I just said them again, because not all antiemetics are equally effective at controlling nausea. So meropitant is an incredibly potent antiemetic. It works extremely well at suppressing the vomiting reflex through neurokinin 1 receptor antagonism. In many patients, it is absolutely the right first-line drug, but there are definitely patients where the vomiting stops and the nausea persists. And I think many clinicians have experienced that patient that receives meropitant and still will not eat, still lip licks, still seems uncomfortable, still appears nauseated. And that is where ondansetron can really shine. Ondansetron is often a profoundly effective anti-nausea medication. Mechanistically, its serotonergic antagonism seems to provide much better nausea control in some patients, especially those with pancreatitis, uremia, chemotherapy-associated nausea, and severe GI inflammation. So clinically, I commonly use these medications together rather than viewing them as competitors. Meropitant is outstanding for stopping emesis. Ondansetron is outstanding for improving nausea. Those are complementary goals. It's worth talking specifically about Emiprev. Emiprev is meropitant. It's the drug we've all come to know and love as a wonderful antiemetic. But one of the key highlights is that it uses a benzyl alcohol rather than metacresol as the preservative system. Clinically, that matters because incorporation of a benzyl alcohol has been associated with reduced discomfort during subcutaneous injection. And anybody who has administered meropitant with metacresol to patients understands why that could be meaningful in practice. Another practical advantage is that Emiprev does not require refrigeration. That can improve workflow efficiency in busy emergency rooms and hospitals because the medication is immediately accessible without needing cold storage handling considerations. We should also not overlook promotility therapy because vomiting patients are not simply nauseated. Some have significant gastrointestinal dysmotility or paralytic ileus contributing to ongoing clinical signs. So metoclopramide can be extremely useful in those cases, particularly as a constant rate infusion in hospitalized patients. It provides both antiemetic effects and promotility support for the upper GI tract. So patients with pancreatitis, postoperative ileus, sepsis, electrolyte derangements, severe inflammatory disease, they may significantly benefit from improved gastric emptying and small intestinal motility. Erythromycin is another option that is sometimes forgotten. At low doses, it functions as a motilin receptor agonist, and it can stimulate gastric emptying. It's not appropriate for every patient, but in selected cases involving delayed gastric emptying or functional ileus, it can be very beneficial. So I guess ultimately, treatment should always focus on the underlying disease process. Antiemetics are important. Anti-nausea medications are important. Promotility therapy can be important. But correcting dehydration, restoring perfusion, managing pain, addressing electrolyte abnormalities, and initiating nutritional support are equally critical components of helping these patients recover.
I hate that this hour went by so fast because I'm like, okay, now let's talk about ways we can implement enteral nutrition and how we're going to do this. So what are you doing for the rest of the morning? Let's keep going. Just kidding. I will be sensitive to everyone's time because we swore we weren't gonna nerd out too far, but that would be clinically relevant. So I hope that we can have all of those conversations at some point. Dr. Byers, thank you so much for joining me. As always, I learned so much every time we talk. Can I wrap it up since we talked about obstructive GI disorder, what's the craziest GI obstruction that you have seen?
Honestly, yesterday was a very interesting case of note. The 3-year-old female spayed domestic short hair had been presented to a urgent care facility for a 2-day history of vomiting, lethargy, anorexia. Initial diagnostic imaging raised concern for hair ties. And so they scoped the cat and removed 7 hair ties successfully. And the patient was dismissed. Unfortunately, that patient never rebounded clinically the way it was expected to. And yesterday morning, the patient was initially presented to the primary care doctor in late decompensatory shock. For example, blood pressure was not readable. Body temperature at presentation was 91.6 degrees Fahrenheit.
Oh my gosh.
And that primary care team did a fantastic job of stabilizing that patient for transport. They called and said, we need to get it over there. we found on POCUS a proximal duodenal obstruction, presumably another hair tie, right?
Sure.
So again, they did a fantastic job stabilizing that patient. The owner transported the patient. We continued to stabilize it. It had the classic severe hypochloremic metabolic alkalosis that one expects with a primary proximal GI obstruction. It also had severe hypokalemia, 2.6 millimoles per liter. So we had to take a few moments, read hours to make that patient the best surgical candidate. We took that patient in for an exploratory laparotomy, found the proximal duodenal obstruction. It was able to be milked back into the stomach. And so instead of having to make an enterotomy or even doing a resection and anastomosis, we only needed to do a gastrotomy to remove more hair ties. But then because there was so much fluid in the GI tract and the patient had been regurgitating, we said, well, the cat hasn't been eating for 4 days. Let's place a nasogastric tube before we move out of the OR. And we're attempting to pass a simple nasogastric tube, and we're consistently meeting resistance. Like, why? There's no reason that we should be meeting resistance. This patient is intubated. There's no way it's going down the wrong hole. Well, we're not going to keep pushing, but I made the decision with the surgeon, because I don't do the surgery. You don't want a scalpel blade in my hand.
Same.
But I was like, we've got to rescope it. I know it was scoped 2 days ago, but I don't know why we can't pass it. So we scoped the cat, and this is where the problems were. I would say this is more significant than the proximal duodenal obstruction that we found. The proximal third of the esophagus was starting to circumferentially necrose. And at the level of the heart base, obviously still within the esophageal lumen, there was a blinded outpouching, a diverticulum. And that also was looking necrotic. And our presumption is that this is progressive necrosis from when those foreign objects must have been in the esophagus for a meaningful period of time, causing damage. Pressure necrosis is our best guess. So we were able to use the scope to guide the feeding tube, into the stomach. So it has a nasogastric tube. And we had to talk to the owner about the potential for stricturing, for perforation. But we wanted to give that patient every benefit of the doubt. So as of this morning, the patient was improving and hadn't experienced any new complications. But I'm really concerned about that patient. But that's one of most recent memory, because it did have those classic electrolyte abnormalities for a proximal duodenal or proximal GI obstruction. But it also made you say, well, why can't I pass this tube when I should be able to immediately? Let's just not keep forcing it. Let's put the scope back down there. Not that we're second guessing our colleagues that performed the scope 2 days ago, but something clearly has changed. So let's investigate it. And I wish we didn't find the things that we did. And I really hope that the patient does well. The family is allowing the team to do everything that we can. But as is always the case, we have to see how the patient can respond too.
Wow, that is wild. I mean, it's cat, so
that's what we all said. We're like, It is a cat. So
yeah. If anybody can come through, it's a cat.
Yeah, I mean, that was honestly the conversation that I had with the owner, obviously in much more detail, but essentially I said, we're going to give him every benefit of the doubt, because cats can do some amazing things.
They really can. That was not what I was expecting you to say when I asked that question, but it's such a good example of all the different concepts that we were talking about, of those serial exams and making sure that we're interpreting everything in the context of the patient in front of us. So now I'm really glad I asked that question. Thank you for sharing that. That was, like I said, that really brought all of the concepts full circle. And again, thank you for all the time. I really appreciate you coming back on the podcast. And yeah, one day I want to have all these other conversations too.
I'm here. We'll make it happen.
I love it. All right, I want to say a huge thank you to Decra for making this episode possible. Thank you so much, Dr. Byers, for joining me. I always love the opportunity to sit down and talk, and wow, I am going to really send all the positive vibes to the patient that we were discussing there at the end and hope for all good things. Thank you so much for your insight once again. Also, a big thank you to everyone who tuned in. If you enjoyed this episode, we would love it if you'd leave us a 5-star review wherever you get your podcasts. It'll help other veterinary professionals out there find other great content that we try to put out there. If you want to hear more episodes, you can click on the education tab on the VetFolio website or find us wherever you get your podcasts. And of course, I want to hear what you thought about this episode and ideas for what you might like to hear from us in future episodes. So email me at dvm@vetfolio.com. You can also find me on Facebook at Dr. Cassie DVM, or we can connect on Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day.